Good morning, everybody. Welcome to Pediatric Grand Rounds. This is Suzanne Mazar, Director of Continuing Medical Education here at Seattle Children's. And from here, I will turn things over to Dr. Scott Weissman, who's going to introduce our guest speaker for today. Thanks so much, everybody.
Thank you, Susan. Good morning to the children's community. It's my pleasure to introduce Dr. Louise Vaz to you this morning. Dr. Vaz earned her medical degree from the Vanderbilt School of Medicine in Nashville, completed her residency in pediatrics at Seattle Children's Hospital, and completed 2 fellowships at Boston Children's, one in Peds ID and the other in health services research. She also has a master's degree in public health from the Harvard School of Public Health. At Dornbecker Children's in Portland, Dr. Vaz is the medical director of the Outpatient Parenteral Antibiotic Therapy Program, the OPAT program that we'll be hearing about today, which helps patients and families transition from the inpatient to outpatient settings to complete treatment of their infections. She attends both inpatient and outpatient settings and has a special interest in refugee and immigrant health. Dr. Vaz's research is in optimization of care transitions and the effect of social vulnerability on health outcomes. She has expertise in care coordination and measurement and is interested in understanding how large health systems can improve care delivery. A quick personal note, when the CDC issued revised guidelines for inpatient antimicrobial stewardship programs in the fall of 2019, one of the recommendations was to have a mechanism for reviewing antibiotics at discharge, in effect, an OPAT program. So our stewardship program here joined with Kathy Mohan and ID to design and implement such a program. I had heard Lou talk informally about the program that she and her colleagues had started at Dornbecker, so we reached out to them to learn a bit more about what they were doing and what they had learned. Not only were Lou and her colleague Kim Felder helpful and generous with their time, with their resources, their policies and procedures, their experience and insights, but they were so humble about the truly exemplary program that they had put together. So we have been so impressed with their work and really inspired by their program, which is just, again, exemplary in every way. So it's an absolute pleasure to introduce Dr. Louise Vaz and to hear about the work that has informed their approach.
Great. Well, it's a pleasure to be with you today, and I wish circumstances allowed us to be together in person, but I'm grateful for the opportunity to speak to you about our work on the integration of stewardship, OPAT, and social needs. I don't have any disclosures today. So years ago, in the first month when I arrived in Oregon, one patient of mine set me on a very different trajectory in terms of my clinical care and academic interests, and I wanted to share that story with you. She was a 6-year-old girl with mastoiditis. She had cranial extension and a brain abscess, and she was admitted on the ear, nose, and throat service. She was on IV antibiotics for treatment after her debridement. And as she was nearing discharge, I was called to organize the antibiotic plan for the family. And I met the family. The mom was at bedside. She was engaged. She was appropriate, and everything went well. They were from a rural town about 5 hours away from Portland. And we were able to find a home health company to facilitate her line care and deliver her antibiotics. The mom was taught about how to give the IV antibiotics before going home, and she understood the plan that we were going to switch her to a medicine by mouth at some point in the near future. They were so excited to go home, and I said, "I'll see you soon." Well, 2 weeks later, with the assigned appointment there and waiting, she never showed. It was another missed appointment. And for some reason, instead of just moving on and doing other work while I was waiting for my next patient, I actually got on the phone and called her home health nurse because she had labs drawn earlier in the week. And I wanted to know, like, why didn't they show up? I thought I was expecting them. And the nurse actually informed me that things were going fine. And by the way, their family of 6 lives in an RV park, and the mode of transportation is actually their RV. And one of the family members actually had to work, so that's probably why they didn't come. And by the way, did you know that her refrigerator is shared with other family members who live in the RV park? And this is where they store the antibiotics, but it's outside and it's locked from the outside. And it's also run by a generator. But it's totally okay. I counted all the vials and she's getting all of her medications. So, well, I was really surprised, and I had to just sit back and kind of process all of that information. And somehow I missed all of this in my discussion and my care planning with the mom. And I was wondering, well, why didn't any of this come up? trying to better understand the situation, it was actually a time of reflection for me. And I had checkboxed all the medical plan stuff, but I failed to really take into account all the nuances the family needed to execute it. And a better understanding of the child's lived experience could have facilitated a better care plan for her family. I also I realized I needed to check my own biases about who I thought would be appropriate for home IV antibiotics. Had I known she had multiple family members living in one small RV and that the refrigerator was outside, would I have felt comfortable doing this all at home? Would I have made her stay in the hospital to finish her IV course? When clearly they had figured out a way to do this to make it work for the family. And finally, I realized it wasn't just about the right bug for the right drug for the right duration. I didn't ask the right questions, and we had the right antibiotic plan. But what would have happened if there wasn't follow up or someone overseeing any of this going on? And what if we just left it to the family to figure this out by themselves in outpatient land? Ultimately, we were able to coordinate a day of the week that worked for the mom and the child and arranged medical transport for the 5-hour drive. We had food vouchers ready for them. And ultimately, she completed her medical therapy without further issues. And a handoff back to her primary care provider indicated that there were access issues and delay to health care that likely contributed to the severity of her presentation. This brings us to our objectives today, and one, to develop opportunities to align antibiotic stewardship and outpatient antibiotic therapy to optimize care planning, to differentiate social risk targeted care from social risk informed care, to examine opportunities to incorporate social risks and need assessment into health delivery for infectious diseases. I'm going to start by saying I'm an infectious disease doctor, and I just wanted to orient everyone around certain language and terminology that we'll be using this morning. The first is around stewardship. So stewardship is an effort to measure and improve how antibiotics are being prescribed by clinicians and used by patients. And antibiotic stewardship programs, also called ASPs, can help clinicians improve clinical outcomes and minimize harms by improving antibiotic prescribing. You are fortunate here at Seattle Children's to have been one of the early adopters around stewardship and now lead the country in efforts around this. And ASPs have been elevated to significant importance with CMS ruling mandating that all hospitals have an inpatient ASP program by the year 2020. And as Dr. Weissman mentioned, be mindful that there needs to be stewardship at discharge as well. This field continues to expand with robust programming around pharmacy expertise, implementation of interventions, tracking of outcomes, reporting measures, and widespread educational campaigns. And while the focus of stewardship has been primarily in the inpatient hospital setting, outpatient stewardship is also gaining traction. This is predominantly in primary care settings and centered around reducing antibiotic use and misuse around childhood infections, such as otitis media and strep and others. However, their hot topic areas include how do you incorporate vaccines to reduce antibiotic use and expansion to other outpatient subspecialty and surgical centers. Stewardship is a young field and many opportunities still remain. And for example, we know that about 30% of pediatric discharges include an antibiotic. And based on a point prevalence analysis of an antibiotic prescribing at 32 children's hospitals, between 2016 to 2017, we learned that about 25% of pediatric inpatients being treated with antibiotics are receiving suboptimal therapy. For example, bug-drug mismatch, an overly broad antibiotic. Stewardship programs would not have reviewed almost 50% of these suboptimal antibiotics through routine review. So this signifies that there are gaps, there are antibiotics that we are missing through these stewardship programs in current state. A first nuance at opportunities to align stewardship at discharge was an early adult study published in 2012, where it was noted that IV antibiotics were avoided in about 28% of patients without adverse consequences, and this required an ID consult at the time of discharge. Finally, it goes without saying that children are particularly vulnerable at the time of discharge and the transition to home, and there's significant work around this topic. As it pertains to antibiotics, we have high potential for medication errors, cultures or lab results that may still be pending that could alter therapy, duration that may be unclear, and also families that may struggle with who to call after they're home for help or to follow up on these studies. This brings us to our discussion around OPAT, or outpatient parenteral antibiotic therapy. You will hear the word OPAT often in this talk, and as Dr. Weissman mentioned, there's a brand new program here at Seattle Children's, and I know familiarity will be increasing around this. So OPAT refers to a program that enables patients to be sent home with an IV line to administer antibiotics. And it came into vogue in the late 1970s and has subsequently been a mainstay, particularly in the adult world, of moving care from hospitals to home. And the main players include an infusion company, which includes another pharmacist and a home health nurse. And there are also a lot of other members of this team. And this is a diagram that one of my partners, Kim Felder, put together to illustrate all the players and levels of communication it takes to get a patient to discharge home on IV antibiotics. Simply, it's a lot of work. But use of OPAT has led to some cost savings through decreased lengths of stay, reduction in hospital-acquired infections and other conditions, decreased readmission events, and enhanced patient experience, particularly in the adult literature. And the Infectious Disease Society of America has endorsed OPAT as probably the most safe and effective way to discharge a patient on IV antibiotics and stipulated key elements of an OPAT program. And these initial guidelines were developed in 2004 and recently updated in 2019. So one of the main features of OPAT is the idea of bundled care. And these are a set of processes and core elements that are done systematically each time for each patient and tailored to an institution and circumstance. And it starts with the identification of the patient that requires the antibiotics with an ID consultation. And at our institution, it's followed by an ID OPAT warm handoff as we talk about the ultimate antibiotic plan for the child. OPAT will meet the patient and the family and assists in care transitions. And this includes ensuring that the antibiotics are prescribed, the family is taught about how to care for the line and how to give the drug and feels comfortable doing so. And in the outpatient setting, OPAT monitors and checks in on the family. This may include labs if needed for toxicity. And we also help with the follow-up, often seeing them in multidisciplinary settings with our surgeons in real time. At our institution, we have an IRB registry to track outcomes, including ED visits and readmissions, treatment failures, and even social needs. And this is all embedded within EPIC. So there are a few caveats with pediatric OPAT. In fact, as many of you know, we actually try not to place PICC lines and other central lines in kids due to the known complications and costs with doing IV antibiotic therapy. And there's growing awareness that OPAT is often used inappropriately and can be a stewardship target. So recent studies of pediatric use of OPAT suggest that maybe up to 40% of OPAT courses could be managed with oral therapy instead of IV. We're also gaining more comfort with oral antibiotics in treatment of serious infections. And a prime example of this includes osteomyelitis. And 10 to 15 years ago, many institutions were still relying on IV antibiotics to treat bone and joint infections. And now it's rare not to be able to use oral antibiotics to treat this. As a result, with our program, we actually modified the PEEV in OPAT from parenteral to include prolonged oral therapy because we favor oral antibiotics whenever possible. And what we've learned over time through our experiences that even with this, quote, lower intensity oral regimen, that we still encounter the care needs and care planning, the follow-up, the issues around adherence, and even intolerance of oral antibiotics. And we have to do a lot of monitoring, similar to what we do in IV antibiotics. So when I discuss the term OPAT going forward, please know that we include both IV and oral antibiotics in this group. So similarly with OPAT, there are many opportunities as well, and there are novel programs that combine ID consultation and ASP review, which have demonstrated opportunities, as we've talked about, to avoid PICC line by switching to a parenteral to an appropriate oral agent. But what other institutions are doing this? It seems to be relatively uncommon. We know that the landscape of pediatric home health nursing can also be challenging. So sending these children out with IV antibiotics is hard, particularly in rural areas with limited pediatric nursing support. And opportunities to improve care delivery and knowledge in these areas is desperately needed. And I'm sure many of our other colleagues in other services, such as cystic fibrosis and shortcut TPN, intestinal failure and rehab, HEMONC, et cetera, are very familiar with these home healthcare issues. Additionally, OPAT is a lot of work, and as we know that transitions of care involve a significant amount of care coordination. And a prior study conducted in 2013 by Banerjee et al. found that pediatric ID physicians who manage patients on OPAT receive little infrastructure or support. And we are curious, has this ever gotten better in the years past? What I'm highlighting here are examples of actual siloed work and what we're trying to work against. So we often draw our boxes around our particular titles and our particular programs and our particular roles. We're guilty of this in ID as well. So we have an inpatient team that provides a consultation, recommendations, and then usually signs off. And we have an inpatient stewardship team, and stewardship's often focused on the initial antibiotic management and clinical practice around guidelines and pathways. However, it's unclear how inpatient ASPs play a role in the discharge antibiotic plan. For OPAT, actually few hospitals even have a dedicated OPAT program, and Seattle Children's is just starting its own just this month. And even for the hospitals that do have OPAT may not be mandatory at all. And within the idea of outpatient stewardship, well, this has been going on for primary care and focused on specific outpatient conditions, but there is a hole in our coverage here, and this is about the discharged patient. Who is watching over them when they go home? And we began to think about, is there a way to leverage our current roles in ID and operate them outside of our silos? And what is the ID role in facilitating treatments of care for patients with serious infections from hospital to home? And wouldn't it be ideal if this was just a seamless process where each party has their unique lens and input in crafting the ultimate plan for the patient and providing them with continued care across the spectrum? The reality is that without effective communication between these ID silos, we still have problems. The narrowest antibiotic targeted to the bacteria fulfills the ASP checkbox, but is this a regimen that could be translated and used effectively at home? For example, an every 6-hour infusion of ampicillin for treatment of group B strep meningitis. Well, how does the family do this at home? How many extra line entries will there be needed? And is there a risk for eclampsies? What if they must return to work? Is there an alternative way to do this, like a continuous pump that the baby will tolerate? Is a more expensive or a broader agent that's maybe once a day, will that need to be considered? Thus, the best ASP drug may not be the best OPAT drug, and this can pose challenges as a patient is nearing discharge. And there's got to be a way that we could work together to harmonize OPAT and ASP together to devise a plan for the family. And for those patients that don't go out on OPAT, well, who's overseeing all of their discharge antibiotics? We realized that we were not the only people thinking about these issues, and in the fall of 2018, we assembled a small group of PEDS ID physicians across the country to help think about these problems and understand the landscape of stewardship at the time of discharge and how ID patients are managed post-discharge. In 2019, we launched a cross-sectional survey among a large network of pediatric hospitals that are mobilized already around stewardship, called the SHARPS network, to obtain some baseline data. And I'm sharing some of this information with you with a manuscript that's currently in progress about the results of this study. And we were able to have about a 91% response rate. So about 67 of the 74 SHARPS hospitals responded. About 44 of these were freestanding children's hospitals. And what we learned was that ASPS is primarily focused on the inpatient setting, but outpatient and ED stewardship is growing. However, only 13 sites had routine review of discharge prescriptions by the ASP, with variability in the types of antimicrobials that were reviewed. The discharge activities that were used by the few sites included the 13 that actually had a formal review by their program at the time of discharge. 22 others had another pharmacist review at time of discharge. Other sites used treatment guidelines and pathways to indicate discharge antibiotics, and some others had electronic decision support embedded within their electronic medical system. But 30% of responding hospitals didn't have any activities around stewardship. Yet, we all know that there's concerns that things are happening at discharge that just maybe really haven't been tackled yet or addressed. And this graph here on the left depicts the main problems, at least perceived by our ASP programs. And this includes about 79% of the sites perceiving that an incorrect duration was noted at least some of the time. And 12% actually said that it often happens at their hospital where a patient is discharged with the incorrect duration. Other problems include inappropriate drug selection and incorrect dose. And these were also the top areas identified for intervention priorities by these ASPs. Further, there are gaps in oversight regarding patients discharging on antibiotics and in the transition from inpatient to outpatient care. Over 60% of sites indicated that an ID consultation was not required for initiation of OPAT at their institution, and only a minority of patients, just 15% of institutions required ID consult for all OPAT referrals, and the remainder 24% exempted certain clinical services from ID OPAT oversight. Finally, decisions around who should go home on IV versus oral antibiotics were primarily based on age and ability to take PO, but they were less likely to take into account, social or economic factors. Lastly, we learned that since the last study done in outpatient ID care and follow-up back in 2013, that really little has changed. There is still minimal support available to support long-term follow-up and management of these patients, whether they're on IV or they're on oral antibiotics. Moreover, 40% of sites endorse spending more than 5 hours a week on non-billable care coordination needs. However, resources such as dedicated physician efforts, schedulers, case managers, social workers, or even medical assistants continue to be really limited for programs and hospitals. This survey was actually really helpful to delineate a few key areas for targeted improvement. One, antibiotics at discharge, clearly a priority, and then also the wraparound care for patients with serious infections. And how do you optimize care teams involved, which includes having team members work at the top of their license. So why are we talking about this? Why is this even relevant? Well, ID has primarily been historically focused as an inpatient and outpatient consultative service. However, ID physicians are now becoming more involved in the growing shift from inpatient to outpatient care. And how will we ensure that patients are well taken care of, no matter their location? Well, this is where healthcare has been and where it's going to be continuing to go. And there's been a growing shift of healthcare to outpatient settings. And this is a good thing. Of course, we know that hospitalizations are stressful events. And when at home, patients have improved healing, improved quality of life. We're able to incorporate the primary care medical home and management and follow-up. And there's also increasing capacity for pediatric home health care within the home setting. But we also know it could be better. And we know that transition of care are real periods of vulnerability. And you have some of the national experts in this with Dr. Desai and Dr. Mangione-Smith, among others at your institution, that have cast a lens on the intricacies of transitions to home and the quality metrics around improving care. What we know is that it could be better, and there are deficits in communication. Follow-up can be challenging, and there may be safety concerns with unresolved medical issues, pending tests, and unclear medication plans following a hospital stay. So how does one show value for this really important translational work, particularly for subspecialists like infectious diseases that are really based on consultative services? I'm rewinding the clock now to share with you how we tried to tackle some of this in OPAT many years ago. And when I arrived at OHSU, I was tasked to start a pediatric OPAT program at our hospital, modeled after a really successful adult program. Leadership supported the funding of a pediatric OPAT program, including a small amount of partial FT for myself and a nurse practitioner, but really nothing else. They did request metrics to prove the value of the program and to justify ongoing financial support. And as you can tell from that first patient I told you about, much of my work actually became care coordination. But I needed a way to document how much time we were spending taking care of these patients and their impact. And there were many moving pieces. And despite a relatively small number of patients, I felt overwhelmed and busy all the time. And with that patient that I described in the beginning, I realized that creating plans from discharge to home was really only half the battle. OPAT was a microcosm of how fragmented our healthcare system can be. The outpatient arena had a completely different set of players that I needed to get to know compared to when I was an inpatient ID consultant. There were different social workers. We didn't even have case managers. There were a variety of these community-based home infusion companies that we needed to know. There were surgeons and other specialists sometimes being transitioned to local subspecialty care and primary care providers that we needed to triage patient concerns and more. And patients were dispersed over multiple states. We in OPAT were that bridge trying to connect it all together. And trying to report on what I was doing led us to consider using a care coordination measurement tool to quantify and qualify what we were actually doing with our time. The CCMT is available from Boston Children's Hospital's public domain. It's a care coordination activities that are currently being done but not accounted for or reimbursed, and assigns them value to get a true cost of care. It's been adapted for subspecialty and primary care, inpatient and ambulatory settings, and it's just not just for complex care. It can be used for other groups of people as well. Well, none of this should be surprising to any of you listening in, that over just an 8-week period, we clocked over 54 hours of non-reimbursable work among myself and our nurse practitioner to care for just 29 patients. And 60% of this was just via the phone, with 129 phone events. However, it was the actual documentation of what we did that was helpful to demonstrate to leadership that what we were doing included obviously clinical management, but also communication among providers, scheduling, outreach to families, care coordination activities. This non-reimbursable work, however, was really meaningful. It prevented 15 emergency room visits. It prevented 2 hospitalization events, and we were able to triage things from the patient's home in 38 encounters, and otherwise help facilitate and coordinate 16 additional subspecialty visits and 13 primary care visits. We only had to refer 1 patient to the ER during this time period. While all this was helpful in demonstrating the value of our program, we had an additional benefit from the granularity of this record keeping, and we stopped to ask ourselves, why are we spending so much time doing this? And the answer was rather apparent after this project. And interestingly, it was not the medical complexity that consumed much of our time, but it was the social complexity of our patients. For example, during this time period, we had a child discharged on OPAT to a homeless shelter. And it also included a rural family with financial stress and multiple sick children at home. We were actively dealing with these issues in the outpatient setting related to this, and began to wonder, would it have been better if we actually had known of this information before we had discharged the patient? And maybe we should have known this, and we should have been better able to anticipate the issues or been better prepared. And we began to think about this critically, about how we could do this better. I also realized that I couldn't be the only person struggling with this at our hospital, but what I did have was a unique lens where OPAT could be used as a microcosm for what is happening to others who lack comprehensive wraparound care. The specific inpatient to outpatient lens affords us opportunities to partner with other services, and we decided to look more closely at children discharging from home from our hospitalist service. And our hospitalist team takes care of patients with a variety of medical complexity, and often those that don't have a subspecialist home, such as cardiology or cystic fibrosis, who often provide very close care and follow-up for their patients. I wanted to pause here to talk about a growing interest across medicine to capture the social complexity of patients and incorporate social needs into health care delivery. We've all long recognized that social determinants of health, those conditions in which people are born and grow, live, work, and age, and the wide set of forces and systems shaping the conditions of life play an important role in determining health outcomes. And there are multiple frameworks and models that address social determinants of health and their impact on health, many of which you're familiar with, whether it's the WHO model or healthy people, et cetera. It comes down to that there are 5 main domains of social determinants of health, and this includes economic stability, education, but also social and community contexts, health and health care, and the neighborhood and built environment. There are upstream and downstream social determinants of health, and upstream determinants of health include elements of the social environment and includes inequities in daily living conditions and inequitable distributions of power and money and resources that create social disadvantages that impact disease and illness. Downstream social determinants of health are the trickle-down effects of the upstream variables, which can lead to more frequent illnesses and higher readmissions. We see this intricately in pediatrics, where adverse childhood experiences, parent psychosocial concerns and issues, and unmet social needs comprise the social determinants of health, which ultimately predispose children to poor physical and mental health outcomes. And in this depiction here, we realize that a family's ability to cope and keep their child in good health may lie in precarious balance. And these risks are all interrelated, and the downstream effects of what might happen if there is a major event or change in the family can have profound effects going forward. The interest in addressing social determinants of health as a core component to address value-based care has dramatically increased in this last several years and have become even more apparent during COVID and the pandemic's effects on families. And this approach includes taking a closer look at our populations that continue to experience poor health outcomes despite a perceived availability of medical care. Specific strategies around this include improving measurement and adopting an assessment tool for this. For example, the AAP already advocates for screening children for social needs, family cycle risk factors, and ACEs. But it also requires you to develop systems to facilitate routine data collection, storage, and retrieval of this information. Next, we need to deepen the understanding of how these issues are linked and how do they influence health. And much of this is focused on new information derived from research and framed by what we know intuitively, that the ability of individuals and families to lead healthy and productive lives is influenced by a multitude of factors. Siren is one group of multidisciplinary researchers committed to this arena. And finally, there have to be strategies around the development of actions to mitigate the effects of social risks. And we are increasingly seeing care settings and hospital and organizations implement interventions to address social determinants of health in innovative ways, such as clinical triggers to alert providers at the time of an encounter that SDOH issues exist, collaborations with community partners to implement programs, and the use of patient navigators. In 2016, CMS developed an alternative payment model to incentivize non-medical interventions by granting states greater flexibility in dictating the type of services that are covered by health plans. And this is why we see health plans becoming more involved in other programs aside from just healthcare delivery. We also have Z codes for social risks, such as employment concerns and homelessness, which are available for billing and coding purposes. And additionally, major organizations are coming out with policy statements on this, such as the American Heart Association's scientific statement on addressing social determinants of health in the care of patients with heart failure. And the Cystic Fibrosis Foundation as well has done amazing work focused in this arena. So where do you start if you want to delve into this area? Well, the first was just trying to get an understanding of the population risks and the prevalence of them. And a multitude of screening tools are available, primarily focused actually on the primary care settings, including Health Leads, Prepare. Many of you are already familiar with these tools. The AAP is a search engine, which is depicted here on this slide. But some of the challenges actually try to include trying to figure out, well, which one to use. There's so many of them, and which ones are adaptable to your clinical setting and the resources that you may have. Others actually may feel that overwhelmed with the idea of opening up a can of worms that are social risks. And you may feel, well, what will I do with this information? And what if we don't have any resources to help them? And I can't fix their problem. And are we prepared to do something if we learn about it? And for those of you that are stuck in this moral conundrum around this, I would argue that if you approach this as just the beginning of a process, and as long as one doesn't stop there and knowing this information about your patients, it will be helpful to you in the end. And I hope to demonstrate exactly how this will happen in the coming slides. One thing I do want to caution our audience entering down this path is around the subject of trauma-informed care. And one of the greatest concerns around screening tools is how to figure out how to use them in a sensitive, appropriate fashion and in a trauma-informed way. Vulnerable groups may ask, why are you asking me these questions? Who wants to know why? I don't see how anything has to do with this with my health. And where are you planning to keep this information? Part of the process around screening includes the manner and care with which these questions are asked, and the vetting around which ones would be appropriate and in what settings and at what level at which one knows a patient. Some of these screens are more important to a primary care provider, having a long-standing history with a patient, and others having background information about social risks and needs can be helpful to make the paradigm shift from asking, well, what's wrong with this family? Why can't they do this? To what has happened to this family such that they respond to me or the health system in this particular way. And thus it becomes important not only to figure out how to ask these questions, but to offer that safety, the choice, the collaboration, the trust and empowerment in all that we do. And without using a trauma-informed approach to this, the possibility for triggering or re-traumatizing individuals increases. I tell you this because it brings us back to our journey with our infectious disease patients and trying to understand that it was our socially complex patients that we wish we had identified earlier on. And our thought was, well, let's join forces with our hospitalists so that we have a broader population to look at this with. And we felt that given our personal interactions with children and our families on the inpatient setting, we may be uniquely positioned to identify risk factors. We may capture patients that may not have had access to social risk screening in primary care, particularly some of those medically complex children that seem to live more in the hospital than they are able to at home. We may capture patients that don't make it to primary care. And hospitalizations may be an opportune time to plug patients into the care or services that they need. Unfortunately, there's little published on social risk screening in the inpatient setting. And as such, we also approach this with real caution about who do we screen for, what tools can we borrow from, who should do the screening, and where should we store this information, and how are we going to do this on a large scale going forward. The result was an attempt of us to just start somewhere, and it was just a feasibility pilot at our children's hospital. It involved a multidisciplinary team of us coming together to think about this, our hospitalists, general pediatricians, social work, clinical psychologists, and subspecialists. And our goal was just to assess the epidemiology of social risk on our hospitalist service. And some unique features of the data collection included that this was caregiver reported, meaning it was on their own terms. They could tell us what they wanted to tell us. It included multiple domains of food, job, paying bills, legal, housing. We were able to get the child's health and medical complexity. We also were able to screen for household risk factors and assess care coordination needs, social support, caregiver mental health, and even the ACEs. We also looked at health access to health care and insurance status and healthcare utilization in the year following their admission. We also allowed parents to checkbox request for social work, consult if any of the questions were triggering or provoking, or they needed or identified areas for extra help. Between July 2017 to December 2017, 249 caregiver patient dyads were enrolled in this prospective study, and a caregiver filled out the survey on social vulnerabilities prior to discharge, and they were sent another survey regarding their experience in the transition to home 7 days after. This data was just stored in REDCap, so it was not in the patient's medical chart. And we were also able to get their demographics, medical complexity, and their healthcare utilization. And what we learned was that social risk screening in the inpatient setting was feasible. It didn't take much time at all. The average time was around 15 minutes for a parent to complete the survey. It could be done whenever the parent wanted. And families shared with us really important and sensitive information. There was actually very little skipped or missing data. And much of this information was not otherwise available in the medical chart. These vulnerabilities were uniformly common and did not disproportionately affect those with chronic diseases. So the patient coming in with bronchiolitis was equally as risk for having a social vulnerability as our medically complex patient. This included 1 in 3 families experiencing markers of socioeconomic stress, including mental health issues as well. Obviously, there are many limitations with this study, and there's a whole list of them I can go into, but some of the issues were that we didn't have a validated inpatient tool and our sample size and the period of time that we did this in. But it left a lot of other issues unanswered about how are we going to do this systematically? And we've started to delve into that, and I'll talk a little bit more of that later. The results of this inpatient work, however, gave us an opportunity to look more at our ID patients because 26 of these 249 patients were actually OPAT patients, and they were captured during the study time period. In yellow are the percent endorsing a risk from the hospital cohort, and in blue, the 26 OPAT patients. On a subset analysis of these OPAT patients, the social risks that were most commonly identified included lower caregiver education, caregiver mental health concerns, economic hardships, the need for assistance with care coordination, difficulty getting time off of work, and inadequate social supports, legal issues, as well as child protective involvement. And this information we would have not otherwise obtained through our interaction, but could have certainly impact the care that we give, from how we talk about an infection from a health literacy perspective, to understanding the intricacies of custody and who actually has consent and who's going to be taking care of this child, and figuring out how best to work with the family with the care plan. With this information, we began to see a different path forward with our ID patients. We've talked about different ways to address social risk. Here on this side over here, this includes doing risk targeted care, where a social risk is identified and or a need is identified. And this includes the involvement of our social workers, giving a patient a voucher, a medical legal referral if available, and these often involve institutional support and resources. The other side of this diagram is a lot more nebulous and seemingly could be free. Could we tailor clinical plans based on what we learned about our families through risk or needs-based assessment? Is this possible, and how does this work? While this does not target the social condition itself, the goal would be to reduce the effect of social or economic adversity in the care plan. Thus, we would make a care plan or medical plan to fit the social needs of the family, particularly for hospitalized children as they're getting ready to discharge. Additionally, if we approach this with every patient in a systematic way, we hope that it would lead to less bias versus targeted screening based on other entities such as insurance status, et cetera. With this in mind, we began taking a closer look at every piece of the OPAT process and tried to better understand where our failures were occurring and what social risks or needs could be implicated in this. Please excuse this relatively simple drawing, as the actual processes around these were so much more complex, but this is one example. One problem we had was that we often had difficulty connecting with families to make and confirm their follow-up plan and their clinic visit post-discharge. And doing a root cause analysis on this, focusing around social needs, helped us better understand and be able to develop a screening tool for OPAT. What were the risks that mattered to our patients, and what were the ideas of how to mitigate and avoid these problems downstream? This includes concern about utilities, whether we had the right phone number or whether they actually had service in a rural area, whether their transportation was reliable, if they had job-related stress, health literacy concerns. You know, there is a perception sometimes why was I even needed to come back to the hospital. Mental health and trust. Some of them just wanted to see their primary care provider. They often felt overwhelmed with too many medical appointments. And there were financial concerns as well. It's too expensive to come back. And we devised some interventions related to this. Our next step was to systematically try and capture how we changed our care plan by learning about a family's social needs. And thus, we undertook another project for a 6-month period where our PA, Kim Felder, did a face-to-face meeting with the families to discuss their social needs, identify risks prior to discharge. These social risk findings were charted as an inpatient note so everyone could see them, and they had specific recommendations made regarding medical care plans and suggestions, if there were any, for social risk. They tabulated the number of times healthcare was utilized and social risks were affected, and that included new social work referrals, if we asked for additional consultations, or if we delayed a discharge because of our involvement. We tabulated also the times the medical care plan changed, changes that were made in how we gave the education to the caregiver, or how we taught them about the infection, follow-up plans, which antibiotic we chose, and even the timing of how these antibiotics were given. These were the examples of the types of questions we asked these families. For each question, it had to relate back to how we were going to take care of the child. For example, you know, does the treatment plan match what the family is able to do with the risks that we've ascertained? And how comfortable are they with this? So this includes understanding whether this is a new diagnosis for a family and what was taking care of them like before. Who lives in your home and what's your routine like? What are your resources and available and support systems? Do you live close to a hospital or a lab or your primary care? And also all the stressors that may be involved in their life. I wanted to give an example of one of our more challenging patients and what we walked into. So one of these patients, this was part of that pilot that we did, and it was one of our patients during that period. And he was a 14-year-old with uncontrolled type 1 diabetes. He also had a large benign tibial tumor. The tumor was removed and they had to put stabilization hardware in. And it was now complicated by an MSSA osteo. So the hardware also got infected. He had to take out the hardware, had to have everything debride, and a new spacer had to be put in, along with extensive wound care as well. And if we weren't successful with this, he might need amputation due to the severity of the presentation. The hospital team, ID team, had put him on cefazolin. He was, the social situation was just noted in the chart to be, quote, chaotic. And he's getting ready for discharge. And there are lots of storm clouds emerging. And here comes OPAT to try and figure some of this stuff out. As we noted here, first was, who do we even talk to about the treatment plan? The woman at the bedside, who is referred to as mom in the chart notes, actually was his bio mom, but the patient didn't live with her due to substance abuse concerns. He actually lived with a woman he called a stepmother, but it was actually his father's girlfriend, and which she didn't have legal custody, and unfortunately his father was also in jail. Meanwhile, there's also a grandmother in the picture who's ready and willing to help, and whom the patient actually really wanted to go home to. The current inpatient ID plan was cefazolin. However, this was 3 times a day, and the stepmother couldn't come over to the house to do that, and the grandmother had other conflicts and was overwhelmed with all of this. We also learned that the patient was also no longer in school. He had been skipping class and was at risk for further issues related to this. So we had decided to switch to a once-a-day regimen that could accommodate this really complicated and dynamic situation. Communication was problematic. The contact information was for the bio mom, and no one had the stepmom or grandmother's information in Epic. There was also no primary care provider that was listed. Additional concerns identified included that his insurance actually lapsed. He had no insurance, and the family needed to reapply. There was no additional money for food if the grandmother was going to take care of the child because she lived on a fixed income. And there was concern about who needed to get the information about the doctor plans. All of this really would have been daunting to figure out in real time in the outpatient setting. And in the end, the child went home with his grandmother, and we advocated for that once-a-day infusion. And this included a home health nurse that provided the family an extra set of support and wraparound care and an extra set of eyes on this child that was already at risk. Multiple communication channels were established. We reinstated his insurance. Social worker was involved, and we actually referred him to a special program called Niche, which I'll talk about in just a minute. Well, this is an example of the inpatient note of another one of our patients that our physician assistant created, citing potential stressors of finances, lack of social support, behavior concerns, and a lack of PCP, as well as recommendations recommending the rurality and availability of oral medications that would be needed to be compounded, recommendations for social work, et cetera. And as you can tell, this is vastly different from our usual ID note, which also usually includes a bug and a drug and duration and a dose of what we want to do. But this is the added thing that we added to our notes. Within a 6-month period, this was back in the winter of 2019, our PA, Kim Felder, captured a total of 29 out of 40 of our OPAT patients for this risk assessment. And she spent 42 minutes on average with the families. And previously unincorporated risk was found in about 80% of the interviews and resulted in care plan changes, including how we gave them education, changes in the antibiotic that were done, how we altered follow-up plans, social work referrals, but rarely did we generate additional inpatient consultations, and rarely did we ever delay a discharge because of what we learned. And as I mentioned this before, routinely thinking through this with every patient can serve as a check on our own biases, particularly implicit biases, as patients get the same set of screener questions and interview process. And there's no way to predict like who may have a social risk or need, or to the extent of the concern, just based on a chart note or insurance status, or where in the state that they may be from. And this implicit bias, or that mental process that causes us to have these attitudes about people or a group of people without really intending to do so, includes also those nonverbal behaviors such as eye contact and proximity issues that patients and families may pick up on. And we all have these fueled by attitudes we've developed over the course of our life. And many of us have taken that implicit association test that's freely available to understand our own implicit biases and how we can push back on its consequences, which are critical from a social justice and equity lens. And so we thought that by doing this systematically, and not just whom we thought or perceived was going to be at risk or may cause issues down the line, enabled us to try this approach. And instead of thinking about, can this patient do OPAT or do this IV course, reframing the question to, well, is the medical plan acceptable and feasible for the family? And what are all the options and alternatives? And this is away from the usual default of just, here's a medical plan, good luck, we'll see you, and hopefully for better success. So as you can tell, there's still much to do and many steps with our work. We are looking at implementing social risk screening across our entire health system, utilizing the EPIC social determinants of health wheel, where EPIC will store the social determinants of health information. We also have other QI projects related to that inpatient risk assessment that we did with our patients, and that includes looking at food insecurity among our parents of hospitalized pediatric patients. COVID has highlighted many opportunities and challenges, but particularly the added advantage of telemedicine to be able to actually get a look at our patients in their own homes to understand their lived experiences as well. And finally, we're fortunate to be in Oregon, where this work has been prioritized, and there's a wonderful number of colleagues and partners in this. The OHA, the Oregon Health Authority, is working on recommending measures that would incentivize screening for individualized social needs. And I'm going to briefly mention two wonderful partners of ours in the next slide due to their really amazing work. But OPIP, or the Oregon Pediatric Improvement Partnership, is spearheaded by Colleen Ruland, and it's one of 20 program partnerships across the country that are similar to this. Lucky for me, they're based in the Department of Pediatrics, but here in Dornbecker on the second floor, right around the corner for me. And they support long-term collaboration of stakeholders invested in child healthcare quality. Some of the most recent projects related to this work includes the development of an integrated client data warehouse that culls the data across multiple databases from DHS, from the health authority, client-based services such as WIC, and data from other external agencies, including the Department of Corrections, to create a social complexity score for every child in Oregon. They also lead the INC effort, and this includes the early identification of children with multiple physical, behavior, and other health needs. They're able to help integrate care coordination and case management, and also work on developing and the implementation of alternate payment models to align quality with accountability. I mentioned niche, or novel interventions in children's health care before as a program. It was actually developed in 2011 by doctors Michael Harris and Kim Spiro, designed to reduce costs, improve health care and health for these youth with complex and chronic conditions who experience significant social vulnerabilities and complexities. And they demonstrate avoidable healthcare utilization or poor response to care models. So, for example, that young man that had uncontrolled type 1 diabetes with the osteomyelitis was referred for this program. And they use behavioral principles and work one-on-one with families 24/7, where the interventionalists provide care within the home or the clinic to help these families. There are two hubs in Bend and in Portland, and they've just started on a large 3-year project dissemination effort with other partners. So in summary, there are many lessons learned during this journey of this program, and this includes an intersection of stewardship, OPAT, and understanding vulnerabilities. And it helps to align stewardship across the care continuum, not just at the initiation of antibiotics, as soon as they hit the hospital and not ending until they get to home. Our OPAT work actually begins inpatient with multiple handoffs, and a better understanding of our patients and families' home situation and social needs is a work in progress. We're aiming for integrated care, modeling what we know that's been done on medically complex children in multidisciplinary care plans, and how do we effectively partner with the primary care medical home. So all this information that we're gathering about these families is not lost in the transitions of care. So I'm going to leave you now with just a few familiar smiling faces that you all may recognize. This is your new Seattle Children's OPAT stewardship team. And I was really impressed by the vision that you guys have created around this, that you're going to ensure that you're giving every patient in your care the optimal anti-infective agent for their condition every day, regardless of your care setting. And I implore you to consider the lived experiences of your patients as you move forward. And I'm very excited for the journey that your own OPAT program will take in the years ahead and how they'll impact care for your patients. I'd like to acknowledge these people here, especially Kim Felder, who I hope is listening today, but I couldn't have done this without her, as well as Diana Yu and our whole team here at Dornbecker, including Team ID, who has humored me in my approach to infectious disease care for these patients. I'll end this now and leave it open for the few minutes that we have for questions.
Thank you so much, Dr. Vaz. One comment so far while we give people some time to type in their questions. Love seeing the evolution of how social health is integrated into medical health. Totally agree. I'm glad we're doing this here as well. All right, from Casey Lyon, fantastic talk, Dr. Vaz. I loved seeing how collecting family information allowed you to tailor care plans. Are you planning to continue that approach, and if so, how?
We are continuing that in a slightly modified fashion thanks to COVID. COVID's been really hard to do this, although we've been able to modify how we're doing this. But yes, we are doing these more in-depth discussions with our families before they go home. I think our next body of work, which is beyond OPAT, is how do we systematically do this for all of our patients? And there's an entire large project that I'm involved with about how to do that too.
And I have a question internally about getting your slides, and we can certainly facilitate that after the talk. If you want to email me, I can connect you. I'm sure
Yes.
Dr. Vaz is okay with that. Thanks. Did you see any correlated change with FES, family experience scores?
Not objectively. I would say that it really helped me feel better about taking care of this patients, if that matters at all. And I think what we did do is ask the members of our team how stressed they were about taking care of these families before we did this whole project around garnering the information around their social risks and needs. And we felt more stressed. We were more stressed. So we did gather that information about our providers. And so after getting this information about these families, I think in one sense, we felt better and more equipped to take care of them. It changed our relationship with them. And the other thing is, yes, I think they were more open in terms of their discussions with us. But I think that's a great idea in terms of formally, doing this in terms of a survey or other interactions. But at least anecdotally, we did get a couple of quotes from them and when our reach out and from a quality improvement perspective, but have not published or done anything on that. And so I agree with you. Yes, in terms of the workforce engagement and burnout, I mean, there has to be a reason for why we were doing this. I mean, all that care coordination that we were doing at the get-go, I think we're able to subvert a lot of that by the work that we're doing up front and getting to know these families better. And it makes our work more meaningful. And it's not just another fax or chasing down a medical record or all these follow-up phone calls. It actually is like a family's experience that we're impacting here.
Well, thanks so much again. Thanks everyone in our audience for your great questions and participation. And thank you, Dr. Vaz, for being here virtually with us. It's 9 a.m., so I'm going to say goodbye and we'll see everyone next week. And thanks again.
Right. Thanks, everybody.
I wish we had a way of doing clapping, but we don't. Not on Webex.
Take care.
Thank you.